Good evening, all. I welcome you all to the 11th edition of TMC Middleox. Today, we have another distinguished alumni from Tanjore Medical College, Dr. Augustus Samuel Dodd. I request Dr. Neelakandan sir to introduce Dr. Augustus to the audience.
Hello, everybody. I am Dr. Neelakandan. I am very much happy and honored to introduce Dr. Augustus Samuel Dodd. He is a very cool and close buddy for me ever since I joined the medical school in 18 August 1977. He is a great personality with a lot of feathers in his cap, lot of medals in his chest, and lot of bullets in his belt. He's an army man, doctor, guitarist, tennis player, so many multi-talented personality. And he is the CEO. Rather, he is a pillar and every stone of it of at Grace Kenneth Foundation, which is situated in Madurai, and he is a pioneer in skin bank. And he has ventured a great mission in Madurai area. Not only in Madurai, it is a landmark mission for the whole of nation. He was a former Indian Army medical officer. He was honored with the Best All-Round Medical Officer Award and two Army Operation medals. He is also a recipient of Dr. Dorairajan Gold Medal for Pediatric Surgery. And he is, apart from Grace Canada Hospital mission, that is medical care, that Grace Canada Foundation is running adoption center for uh, children abandoned by parents. So it is one of the networks for adopting children left over by the parents, and it is one of the great centers for uh, uh, adoption of children. And they are taking care of all children, whether they are ill or good. Mostly they are mentally retarded. I have seen the center. I visited the center long ago, and they are taking care so well. It's an honor to visit that center. And he has got many interests. He's a rhythm guitarist, vocalist, and he's got a lot of dogs. He's a great lover of dogs. And he's very famous in Instagram also. And he's also doing aircraft training, piloting, and very good personality. He's a great human. That is the most important thing. He's a great human. I'm very honored to invite Augustus for this. And I have to mention about his wife, uh, Mrs. Priya, and he has got two sons, Rodney and Benjamin. Both are pilot trainers. Thank you, Dodd. Thanks for opportunity to speak about Dodd. Thank you, Venkatesh. Thank you, Murali. It is Dodd. It's your turn.
Good evening. Thank you very much for your kind words. Shall we begin?
Yes, sir.
Podium is yours.
Thanks, Niels. So, good evening and thank you. We shall begin the day with a question and end the day with a question. So, name one medical condition that throws the entire physiology into chaos instantly. Anybody?
Burns.
Wonderful. That's what it is. And everything is thrown into chaos. So this chaos happens at 49 degrees Celsius. And beyond that, the damage happens. And generally, the ideal temperature for us to either bathe or drink something is 38 or 39 degrees Celsius. And why I call this as a world is there is very little awareness regarding comprehensive burns management. It is nobody's baby. It's in no man's land. And I can call it the state is in an entropy. So we'll go ahead. So we'll see skin from a different perspective. We'll see it as a stem cell bank. We'll see it as a dysfunctional endocrine organ, and we'll see skin as a savior. So men trip not on mountains, but tumble on stones. When I say this, there is no dearth of knowledge. We are all specialists and super specialists. But when it really comes to healthcare delivery, application of knowledge, particularly in burns, we terribly falter and we tumble on these stones. So that is a real problem. This is what we have to see. So global statistics, every 3 minutes, a child is taken to the hospital due to burn injury. The World Health Organization reports approximately 180,000 deaths globally each year. And annually, around 11 million individuals require medical care for burn injuries. And burn crisis in India. In India, there are between 7 to 8 million burn injuries reported each year, resulting in approximately 25,000 deaths, emphasizing a significant national health problem. So the evolution of burns care, I think Murali will enjoy this. Burns care has developed significantly over 4,000 years. As noted by Oliver Wendell Holmes, medicine is the hair of all ages. So we're not doing anything new. We are just continuing a process. And as early as 600 BCE, Shushruta, he could describe the level of burns. He could say first degree, second degree, third degree. People started using honey for treatment. They started using aloe vera for treatment. And in the 19th century, Rhesus, he said, first immerse in cold water and remove the dead tissue. That is what we are still doing after thousands of years. So mortality patterns, this is very interesting. So trimodal versus bimodal. So what is trimodal pattern of death? When you get a burns patient, the burn patient dies immediately, or there is an early death, or there is a peak around the third week. This is what happens. But now people say, particularly for polytrauma, there is a bimodal pattern because of evolving better healthcare. But still in burns, most of the times we see this patient dying in the third week, and this we call it a trimodal pattern of death distribution. So why a child dies? So in COVID, most of the times we thought it was only the host response that killed the patient. Similarly, it is the host response to burn that really kills the child. Next is hypoglycemia, one of the most neglected things. Most of the early burn patients, they have to be given, particularly anybody less than 20 kg. Dextrose addition is a very important during resuscitation, and hypoglycemia in a child is a major killer. And hypothermia. See, most of the hospitals may be centralized air conditioned, but in burns care, you have to have rooms with special temperatures. You cannot have the same temperature as the rest of the hospital, and hypothermia in particular can kill the child. So host response, we talk about three things in host response. One is metabolic storm after the burn, the inhalation burns, and sepsis. So understanding temperature, heat, and cellular damage. So what is temperature? Say, take a glass of water. The amount of agitation of the atoms and molecules, they are just vibrating. This is temperature. Say in hyperpyrexia, what happens? Your neurotransmitter molecules, they start vibrating at about 107 degrees Celsius. I mean, Fahrenheit, and this, they don't transmit anymore, and you throw a fit and you can die. So temperature is the state of agitation of the atoms and molecules, and heat is the transfer. And at 49 degrees Celsius, this cellular damage happens, protein degeneration, disruption of cell membranes, and leakage of fluid, and vascular stasis. All these happen around 49 degrees as they progress. So this is very interesting, burn depth and stem cell reserves. Understanding the relationship between burn depth and stem cell availability in healing process. This is skin, you know, you have got a dermis, you've got a epidermis and hypodermis. We have certain classifications. And when you look at this picture, this is how the burn depth is classified. So we call it first degree burn, second-degree burn, and third-degree burn. Sometimes we call it 2A and 2B. It all depends on the amount of stem cells left. So we have about 4 types of stem cells. One is interfollicular stem cells. You can see on top, it is at the basal layer of the epidermis. Then in the dermis, you have follicular bulge stem cells as well as sweat gland stem cells. Here, the follicular bulge stem cells are more important. And you also have perivascular stem cells in the fat area. As a surgeon, as a plastic surgeon doing surgery, it's very important not to knock off all your fat. I've seen some surgeons using a cautery and doing a facial level excision. But in burns, you have to do a tangential excision because you have to preserve all those perivascular stem cells which really aid in healing. So it's like a bank, your superficial stem cells are like your savings account and your deeper stem cells of FDs. So this is your normal skin stem cell bank that helps your tissue heal. So this is my team working, and there is an ebb phase and a flow phase in burns. The ebb phase lasts from about 0 to 48 hours post-burn, marked by decreased metabolic activity and hormonal shutdown, prioritizing survival during this critical time. The insulin suppression, growth hormone suppression, everything is because survival is most important and there is literally a shutdown. And in the flow phase, 48 hours and beyond, lasting 48 hours and beyond to several weeks, is characterized by a significant increase in metabolic rate known as the hormonal storm, which is crucial for tissue repair and recovery. Everything, your catecholamines, all your hormones are in a surge. So this is an interesting concept, burn wound as an endocrine organ. The burn wound functions as an endocrine organ. Actually, we can call it a dysfunctional endocrine organ, leading to a metabolic state often referred to as a diabetic state of injury, characterized by insulin resistance and hypermetabolism. So during this hypermetabolic phase, there is a lot of substrates forming, but they are not utilized, and insulin is there, but insulin resistance is there. But this is described as a diabetic of injury. And we were in early school days, we were taught, that diabetes is about poverty in the place of plenty. If at all you have to describe this as so much of substrate, but insulin resistance, we are not able to use it. This diabetic of injury is a true state of poverty in the state of plenty. So in burns, we rather approach, it's not ABC, we call it CAB, circulation. When a child comes, we have to start 2 lines for a particular reason, because there'll be 1 resuscitation line and 1 maintenance line. As long as the airway is concerned, when they come with injuries, there'll be a fractured mandible, there can be claw, there can be any foreign body obstructing the airway. You have to look at the airway, and breathing patterns you'll have to see, particularly for fractured ribs. Of course, particularly even children, they'll be playing around the Sivakasi and all. We get sometimes 10, 14 of them in a bulk, in a bunch. So going to special organ injury, lung burns. An adult lung is about 100 square meters of surface area as far as your absorption or gas transfer surface is concerned. So most of the times when you have a facial burn, singeing of nasal hair or lip or change of voice, you have to suspect lung burn. So lung burn is one of the bad prognostic indicators in a burn injury. And eye injury, it's very important. There are ways to heal with even cadaveric graft. So eye injury, you have to take care of eye injury. And HAT criteria. This is not very precise or perfect. When a patient comes, there is hypertension, altered sensorium, and tachypnea, you suspect sepsis. So next we go to the burn assessment. The most important thing is to assess the area of burns, and we use what is called a Lund and Browder chart for accurate assessment. This is particularly for children, and it's very important to record the weight, and also we record the height for the purpose of nutritional assessment. So Lund and Browder chart, I've already shown you the chart. It gives you an accurate assessment, and weight is important. And fundamental principles of burns care. So reverse isolation. So corona times, we put a patient in the ward so that they don't give us corona. But in burns, we put the patient in reverse isolation so that we don't give an infection to the burns. This is called reverse isolation. To the left, you can see a picture. This is almost the design of our burn center. This is how we have about 5 independent cubicles in one portion. This is showing one portion. So this is the concept of reverse isolation. And burns bath is very important because while we give a bath, the total colonization bacteria we can reduce. Patient also feels comfortable. And again, bath temperature has to be around 39 degrees Celsius. So one little joke about the bath. So our people, most of the times, they think, bath is going to give you infection. So I operated on a patient, hernia raphe, and I saw the patient after 1 year. So I asked the patient, how you are? He said, I'm doing fine, sir. I forgot to ask you one question. I asked him, what? Sir, can I have a bath? So unless you insist, most of our people are not going to bathe. So fluid, electrolytes, and acid-base management, this is one of the most important things we have to do. So as far as fluids are concerned, we use a Ringer's lactate for resuscitation. We use a Linden-Browder chart to calculate how much you have to give. And electrolyte management is also important. What we do is burn surface area into 3 ml into body weight is the calculation. And I'll give you a simple formula to set your flow meters. So if you have 3000 ml divided by 100, it'll give drops per minute. Any 24 hours volume divided by 100, roughly, it gives drops per minute. And any 1 hour volume divided by 100, it'll give you, divided by 4, it'll give you drops per minute. Supposing 100 ml in 1 hour, you divide it by 4, it'll be 25 large drops. That is the calculation as far as the fluid rate is concerned. So hypotonic fluids, one of the commonest mistakes we make is picking up isolate P for resuscitation. Isolate P is a hypotonic fluid. Most people use isolate P. It is not a right fluid to use. You should use only Ringer's lactate for resuscitation. In the parallel line, we use a half NS so that we go with dextrose normal saline, half dextrose normal saline for the maintenance, and for burns resuscitation, we use Ringer's lactate and never use hypertonic fluid, particularly isolate P has got a lot of potassium also, so initially we don't use it. So dextrose administration is essential for children under 20 kg to maintain appropriate blood glucose levels during resuscitation. So never forget to add dextrose because most of these children, they cannot handle hypoglycemia, particularly children less than 20 kg, and you have to give dextrose. So how much and how to monitor must be guided by urine output to ensure adequate hydration and organ perfusion. Generally in children, we aim at 1 ml per hour. Per kg is what we generally we plan to achieve. Potassium management requires caution. Avoid potassium in the first 24 to 48 hours until normokalemia and adequate urine output is confirmed. So burn wound infection, how do you know a wound is infected? So when I see this wound, it's very clean. But when the scar, it becomes unstable, it's sticky. If it is green due to Pseudomonas or it is rapidly evolving, you know a burn wound is getting infected. So when it is getting infected, the best is to do a burn biopsy, a full thickness biopsy of the burn, and pulverize the tissue and look for the organism. So anything on surface is going to be misleading because on the surface you have all kinds of bacteria growing, but unless you do a biopsy, you will not know exactly what infection is on. So sepsis tracking, we use various types of scores. We use ABA, American Burn Association score, the pediatric sepsis score, modification like Phoenix scoring, and we use PSOFA. Of all these scores, PSOFA will be useful to you if you're doing research and it gives more information. So this is sepsis tracking. So next we go to pain management, effective pain management in burns care. Morphine via IV bolus at a dosage of 0.1 milligram per kg per dose. So one of the common mistakes we do is to not give enough of painkillers. So most of the times, that is what we are scared. We are scared to give, but this is the dose. And when you titrate the dose, it's very important to keep the child calm. And if you give adequate sedation, the child will do very well. So next, other supportive measures, steroids. In certain cases of sepsis, we still use and not as a routine. And gastric protection, this is another interesting thing. So gastric protection is important because of Curling's ulcer in burns. So we give sucralfate and we don't give a PPI. PPI generally should be avoided because you do not want to reduce the gastric acid levels, because most of the times the sepsis happens because of the bacterial translocation, and the colonization of the gut with bacteria should not happen if the acid is normal. So if you reduce the acid, there is a chance of more infection. So sucralfate alone is ideal. So combining sucralfate with PPI is not a good practice. Don't do that. DVT prophylaxis in adults, we use fondaparin followed by apixaban. In children, enoxaparin is recommended, but we don't have much of experience as far as DVT prophylaxis in pediatric age group is concerned. Eye care is very important. We always take an ophthalmic opinion and take care of the eye. And physiotherapy is a must, and it is a very important thing to do. Next, nutritional guidelines for burns patients. Effective nutrition is crucial for recovery and healing in burns patients. We take care of nutrition to a very fine aspect, and we do nutritional management very well. First is, when gut is available, use it. Enteral nutrition is number one. Then very rarely we use TPN, but we use our supplemented parenteral nutrition. So we even give a TPN fluid supplemented in certain cases, but the recommendation is first 3 to 4 days, a bit of starvation is okay, even up to 6 days. But after that, it's very, very important to keep your calories and proteins going. It's very important. And Galveston formula we use to calculate the calories alone. Protein we calculate separately, and we use Mosteller formula to assess the burn body surface area. So special consideration in burns. So electric burns, it's always tricky. Electric burns, initially you can have cardiac arrhythmias, and after that there is vascular injury, and you can have all kinds of, they go for amputations because of vascular injuries and abdominal infarctions, everything you see in electrical burns. One particular thing is in electrical burns is they can develop delayed paraplegia, quadriplegia, delayed things. And also when the patient goes under anesthesia after 2 to 3 weeks, we have seen patients going in for cardiac arrest. Most of them are revived. But electric burns is always tricky. We spoke about inhalation and injuries, lung burn. And next, the most important is abdominal compartment syndrome. So we all know the normal blood pressure around 120/80, but when we ask people what is a normal venous pressure, most of us may not know. So venous pressure, first we learned in laparoscopic surgery when we don't raise the pressure over 14 millimeters of mercury. So usually the venous pressure is around 14 millimeters of mercury. Above that, if the abdominal pressure goes up, there's going to be your vascular, there's going to be a tamponade, and your cardiac output is going to be less. And sometimes we have to even do a laparotomy to relieve the abdominal compartment syndrome. So you can see a skull. This patient is still alive with us. It's more than 1 year. We tried everything possible. The skull is still open. He just wears a cap and goes around. So what are the options to cover your raw area? And number one is autograft. Autograft, consider the gold standard for skin cover, providing active skin signaling and improved healing outcomes. So active signaling, what we mean is once we put a graft, all your metabolic storm is going to reduce and the healing process starts. And in this process, autograft, they carry the stem cells. And when the stem cells go, the healing process starts, and mainly the metabolic response to trauma is reduced. An autograft is wonderful. If you have smaller graft, we have meshes. We can expand the graft to 3 times, 4 times, and you can also use the autografts. Next is allograft. Allograft is very important. We have a skin bank. We are probably one of the leading skin banks in the country. We have done about 100 retrievals in the last couple of years. So allografts are very important for 2 reasons. One is when you don't have an autograft, allograft is going to help reduce your metabolic response to trauma, and it reduces the pain, and it reduces the mortality and morbidity. It really works very well. I even tell people the allografts take better than the autografts. Once the allograft takes, you can see the patient really settling down. The metabolic response to trauma reduces, and you give the patient a good chance to survive. So what we do is about 3 weeks second or third day, we do a excision and put the allografts, and this graft stays for 3 weeks. So sometimes we do what's called a sandwich graft so that you don't have to do a regraft. But if the allograft grows, you can always go for the autograft in the rest of the areas, and the patient can be saved. And skin bank and allograft is one of the key things we do. This is a game changer and really changes the lives of people. We do quite a bit of work. I'm not going into the real details now. This is about our allografts and other options. Collagen is very common, particularly 2A, 2B burns in children. Collagen is a wonderful dressing, except that it gives a little bit of pain. We wash it off around 5th day or so. Most of the collagens, it works pretty good. The patients do very well. Other things, we have acellular dermal matrix, ADM. So, and also we have that biodegradable temporizer matrix. All these are very expensive. We try it in smaller areas. It works. So, importance of psychological support. So, psychological support plays a crucial role in overall recovery of burns patients, helping them cope with trauma and emotional distress. So, it is very, very important to keep the child comfortable. So, we give them some toys. We see that they are emotionally stable most of the times. So, next is addressing children's needs. Children in particular may experience heightened anxiety and fear after a burn injury, making psychological support essential to address the unique needs. So it is team approach. Integrating mental health professionals into burns care team can improve outcomes by providing comprehensive support for both patients and families during recovery. And today being a mental health day, it's all the more important. So mental health is the most important thing in burns recovery also. So advancements in burns care, a glimpse into the future. So one of the things is SBOT. The concept is most of the times when you have a burn injury and vascular stasis, your RBC is not going to reach particular points, where your body fluid is still going to reach that point. So when you put a patient in a hyperbaric oxygen chamber and increase the atmospheric pressure of oxygen, you're going to dissolve oxygen in the body fluids. So this is likely to reach the places where your red blood cell carrying oxygen cannot reach, and it can help in healing. It's a newer concept. It is coming into Tamil Nadu. We are ready to try it, but we may implement it very soon. And it's one of the newer things now. And the next thing is about your stem cell therapy. People are really working on stem cell therapy. It can be a game changer. And tissue culture is another thing. When you have very little tissue left, you can do a culture, your keratinocytes. You have sprays, you can spread it on your skin. And there are so many ways to do your tissue culture. And the next big thing is we are talking about quantum medicine. We talked about it about 6 months ago, I think. And recently, they got a Nobel Prize for quantum tunneling. So it's very interesting. So these are the frontiers that are open. But in my opinion, most of the things at a molecular level and atomic level, we have reached a plateau. If you have a breakthrough at a quantum level, things are going to work really better and better. So the scale of burn injuries, there is an urgent need for improved medical facilities, awareness, and treatment options. The next is efforts and challenges. The elephant is in the room. I told you when I started that burns management is in the It's a gray area. It's nobody's baby. Who's going to take care of these patients? We can't leave them to plastic surgeons alone. They're interested in the plastic work, and intensivists are not very keen to do that. I don't see the physician. I don't see the pediatrician coming in. I don't see the pediatric surgeons coming in. So this is a real problem where comprehensive burns management is a real challenge. As a team, people will have to get together. And unless you do that, so many people dying in the country, it's going to be a problem. I said I will end this with a question. So we started from the basics. I always insist that it is the basics, your fluids, electrolytes, acid base. These are the things that is going to help the patient and not your very modern things, though they are very likely to help. So in this context, I'll end with a final question. What is EGG? Anybody?
EGG is an egg.
That is fantastic. So why I'm asking this question is never forget your basic. Egg is important as a protein for burns and healing and everything. So never forget your basics. Do your basics right. So I just gave you a quick bird's eye view without getting into a lot of detail so that I just wanted to create an awareness that burns is very important. We have to get together, all of us, to do a good job of burns and save our children. And that is the end of my talk. And thank you very much. It has been a great pride and privilege to be amongst you. Anything you ask, I'm ready to answer because, like AI, I can always say something wrong. Hello, Murli.
Hi, Sam. Wonderful lecture. I enjoyed it. I request you to mention about how you do the skin banking and how you harvest the skin from various colleges to various hospitals and how your team is working. This is first question. And the second question is heart transplant. Is it possible from uh, blood group compatible person to person? Heart transplant is it possible?
So I'll take the first question now. We have two kinds of donors. One is brain dead, and the second is people who are dead. Like corneal donation, we can take the skin within 6 hours. There are lots of people now, people are very aware and they come forward to give the skin. As far as brain dead is concerned, we are part of the organ registry, organ donation registry of the state. So wherever there is a brain dead case, when people are harvesting the other organs like heart, liver, we get a call. Our team immediately goes there. We harvest the skin. We have a very good harvesting machine, which costs about 14 lakhs. You can do a rapid harvesting and it takes only about 1/8 of the thickness of the skin. So we bring it here and we process it. And in the process, we expand the skin and the skin can be kept for up to 5 years. So 5 years is a time, but with a demand, now we act as a nodal center. We have started giving even skin to places like CMC Vellore, some of the hospitals in Bangalore, Kaveri Hospital. All these people are accessing skin from us now. So this is regarding the donors, the retrieval, the storage, and I'll also tell you, there is no charge for this, but only the government has fixed a service charge of 20 rupees per square centimeter. So if somebody accesses skin for you, it is not a this thing, but they pay the service charge. And even if you want the skin for anywhere, you can always send somebody and you can collect it from us. That is question number one. And hand transplant is not my field. My plastic surgeon is not with me right now. I see a number of heart transplants working beautifully and a lot of people. And honestly, I have no idea about heart transplant needs.
Thank you. Because heart transplant has not been in vogue from cadaver or from brain dead person.
Yes.
Because mostly it is autologous autografting from the back of the scalp to the front of the scalp.
Yes.
That's how they do it. But the rejection, because of the rejection and because for minimal issue, you have to take immunosuppressant. So no center has started a heart transplant from donor.
Yeah.
I'm just asking whether somebody has started like that, has
No,
tried
I'm
it.
not one, but I'll go to another point. But what they started doing is, besides the cornea, from the limbus, they take the
Okay.
stem cells and they put it on
Okay.
an amniotic membrane and they put it over the burnt cornea and they're able to regenerate the cornea and give eyesight to people. So this is a very interesting thing. They take the stem cells from the limbus of the cornea from the deceased donor and it has been transplanted successfully on people. Particularly, they put it on an amniotic membrane and it is working. I saw a leading doctor doing this recently, a video, and I interacted with her also. It's very interesting for eye injuries.
And am I audible? And I had a chance to dress 60% burns with the amniotic membrane,
Yes,
and also part of the placental tissue also.
yes,
And the biggest problem was next day dressing. After a couple of days, when you do the dressing, it will be stuck to the wound. You cannot
yes.
remove it. It will be very painful also. And what's your experience? You leave the skin there and forget about it. Then normal skin will come back or reject the donor skin.
See, thing is, what we have seen is it really sticks very well early, and every bath after that, it slowly goes. And most of the times, if it is not really, it's only a 2B or something, you'll see the epithelial tissue islands beautifully coming, and 60 to 70% of them they get away without another skin grafting. But
Okay.
what we do also is because we do a meshing, we put an autograft also over the allograft so that you give islands of stem cells or your own autologous tissue there. So they also get away with it without another need for another skin grafting.
Okay.
But in my experience, we have used placenta early days, 30 years ago. But because you have this cadaver skin, and it's really easy to use, and it's very effective, and I've not seen even an infection with this, and it works very well.
Thank you.
Thank you very much.
Why is it that we don't have many centers, sir, especially when it comes to burns management? What are the kind of impediments? Because it's even in Chennai, it's very hard to find dedicated burns units. And especially when you have 30% burns or acute skin failure with burns, it's extremely difficult to manage patients here. Most of the bigger hospitals also don't have a dedicated burns unit.
So this is a very interesting question, sir. One of the things we'll start from our teaching when you're trained as a surgeon. Unless you are interested, you're not going to study surgical physiology. If you don't know surgical physiology, you cannot treat a burns patient. So it's not about putting a graft or anything. So you start with that. When I say that, there should be people who are interested in every aspect, comprehensive aspect of burns management, which is very difficult. And I won't say it's a wrong thing, but most of the corporates, because the patient is going to stay for 45, 50 days and he's going to occupy your bed, this may not be a very good revenue generation model because he's going to block the bed. If you are doing something else, you can generate more revenue with that bed. I do not know that is one of the reasons, but the team training, everything matters. When you have somebody surviving about 70% and all that, it is totally a teamwork from the beginning to end, which is very difficult to achieve. And I've seen why I say men trip not on mountains but tumble on stones. Every day, even in spite of all your instruction, you will see something going wrong. So unless you're micromanaging, somebody's really interested in micromanaging, burns management becomes very difficult. So maybe that is one of the reasons why we don't have many centers, because you have to have an interest in that. My interest started because 30 years ago I was in the army. Another thing, we also take care of orphan, abandoned, and surrendered children. They come with cigarette burns and they come with scalds, oil, hot water. So this thing, I always say, see, gift, skin gift life is one thing, but right to live life. So a child should live. So how to save the child? So we work on these things so that we can save a child. So because of your personal interest, and you can count the number of burn surgeons in the country, maybe 10, 12 interested in really doing burns.
Very true.
Thanks, Dr. Augustus, for a wonderful presentation. Like you said, I think it's the passion, it's the choice of the field. In diabetic foot also, there are not many surgeons who are really interested. Do they think it's a thankless job? It takes a long time. It's not glamorous. Again, here again, you require team effort and it takes a lot of time, but finally the limb salvage is possible if you are dedicated. Same thing may apply to burns. And your comments on vitriolage, on acid burns or alkali burns?
Yeah, see, alkali burns and acid burns are not uncommon. So initially, we give a wash and I treat them like, because, they get deeper and deeper. So particularly when it comes to alkali and acid burns, one of the most important things we should know is particularly eye burn. If it is an alkali burn, it's going to be worse than an acid burn. Because an acid burn is on the surface, but alkali burn will go deeper and deeper. And I heard, recently that even people playing with this chunambu lime, if something goes into your eyelid and it stays, people can become blind. Children can become blind. So these, lime water, you have all kinds of, we have had people fallen into a molten tar completely brought here. So we had to find a way. We used petrol to get that off and all these things we try. So acid attacks are not uncommon. We get a lot of them.
And the ban on crackers and or the reduction in the use of crackers, has they brought down the burns during Diwali in your place, Madurai?
See, I'll tell you something. Since the bursting of cracker is restricted to Diwali day, rest of all days, 365 days, we have firecracker injuries. Every day they are bursting crackers. Children. Okay, so there is, I do not know about your place in Madurai, there is not a single day where a firecracker doesn't go. And our people are so careless with children, you won't believe. So we get quite a number of firecracker injuries, very bad injuries with children, very many.
Regarding metabolic therapy, there are anabolic therapies which have been tried, like growth hormone therapy, IGF-1 therapy, but they're all very costly and largely experimental. One of the soft indications for growth hormone when you talk about in acute stressful conditions is burns.
Yeah. Yeah, like, when I started, like you say, there is no other injury that completely challenges your whole system, your immune system, your endocrine system. Everything turns topsy-turvy when in burns. And so how I, explain to people about why I should be operating on it, they don't understand. So I always tell them, if there is a bit of tissue like an appendix sticking to you, dead, it's going to kill you. The same way, if a lot of tissue is sticking to you, it's going to kill you, not only because it's getting infected, because of the subeschar fluid, which is a powerful mediator of immune response with all these inflammatory mediators. It's going to be very bad unless you remove them as early as possible. So make a burn wound as a normal wound as early as possible. We start, doing tangential excision as early as third or fourth day. Keep slicing them off, then they'll survive. So if you leave it, they'll die.
And what is the topical antibiotic or antiseptic you advocate in your practice?
So, yeah, number one topical agent, acid ointment or cream, we use silver sulfadiazine. Gold standard, nothing beats silver sulfadiazine. And in silver sulfadiazine also you have molecular silver as well as ionic silver. Ionic silver becomes very painful, so we don't use ionic silver. We use the standard silver sulfadiazine. And when it comes to all these gauzes or medicated dressing material, most of the times we use only silver material. We have chlorhexidine material and also material with amphotericin B and all these antibiotics. But in specific cases, we use them. Most of the times, it is silver sulfadiazine that works wonders, and that's the gold standard.
Thanks.
So there are, thing is, some people have tried even early insulin therapy, the first 2 days and all that. So I've read all that, but most of the times we have used high doses of heparin. We have tried everything in early days, but now we stick to the standard protocols, which works pretty well. Keep the wound clean and to keep the patient alive. Yes.
Yeah, this was probably the Vandenberg's study, the Leuven study, where in surgical ICU, especially the cardiac ICU, they
Yes.
kept the tight glycemic control with the intensive insulin therapy, and they improved the mortality. But subsequently, in all medical ICUs, we have
Yes.
clearly shown that tight glycemic control actually increases mortality, and we opt for moderate glycemic control, anything between 140 to 180 milligram per deciliter.
Yeah, that is what, we just ask them to keep it around, mostly around 150, around that. That is what, we generally, it is advised, and yes.
In setting of severe sepsis with burns,
Yes.
and you're not able to identify a clear-cut bacterial focus, your biopsies are negative.
Yes.
What kind of antimicrobial problems you face? What are your common go-to antibiotics?
The thing is, most of the times we may not have a very specific report because all your surface culture, everything is most of the times misleading. So
Okay.
always, unless we can get to the organism, start broad is the thing. So our protocol is mostly very early days. They may not need an antibiotic. Just the surface infection does not need an antibiotic unless it becomes invasive. So you know the signs of invasion, and you can also see the signs of sepsis. But once it sets in, for Pseudomonas, this thing anchor antibiotic is ceftazidime. And for MRSA, we now use tecloplanin. So most of the times, these are the things, and we use a combination of broad spectrum, focusing on that. And mostly around the third week, we also use fluconazole because, to prevent colonization, fungal colonization. So these are the basic protocols. And if at all we have anything very specific, we don't go for any other antibiotic. Generally, these things work.
Thank you.
And early acute kidney injury, we go for early dialysis, and that also really helps. Right. And another thing is, between a person who's, it's the World Mental Health Day, a person who has sustained an injury, a 60% burn due to a suicidal burn and an accidental burn, a person with accidental burn always does a lot better than a suicidal burn. Because if there is no will to live, they don't do very well. And one of the real good things, about a few years ago, there is a place called nearby, not Sivakasi. There was a firecracker blast injury. We had 14 patients between 40 and 60% burns, including a couple of children. So all the 14 survived. One of the reasons is it was a blast. They had fractures, they had flame injury, but there was no lung injury. Put it the other way, from Korangini, we had about 7 patients. They all arrived late, all with lung burn, and all of them died. So these are the contrasting scenes we have had.
Yeah, if there are no further questions, I think we can wind up today's session.
Yeah,
and I would like to ask Sir to give a series on this. So we have kind of a general outlay about burns and what it looks like in the future. So more specific aspects of burns management is probably we would need. And if Dr. Augustus would kind of help us, we can have a series on this. Can we do that,
Definitely.
sir?
Yeah. See, thing is, everything we said, we can talk for hours together, but, I just wanted to give you a quick bird's eye view so that, we cover everything. Basically, like, you said, create awareness. Burns is something, that needs definite attention from all of us.
Yeah. Are there any comments?
Hello, sir. This is Dr. Chaitanya. I am Augustus sir's plastic surgeon, sir. So sorry to joining lately. I would like to add upon sir's presentation. As Bala sir has asked about sticky membrane of amniotic membrane in burns, especially, sir. Can I go ahead, sir?
Yeah, please.
Yeah, please go ahead and also answer the
Also,
second question regarding heart
yeah, burn
transplantation.
centers.
Yeah, so he had
Yes,
another
sir.
question regarding heart transplant. To answer both the questions, please.
So hate transplant. Okay, so I have. I joined very lately. I'm so sorry, sir, for that. Actually, first of all, coming back to the question, sir, amniotic membrane sticking to the burn wound, sir. This was actually tried previously. In the initial days, the amniotic membrane was taken from the cesarean section, seronegative patients, sir. And then after cleaning the wound, as sir mentioned, thoroughly we have to debride the wound as we do usually in day 3 and day 4 tangential excision. And afterwards, we try to apply the allograft. In previous days, initially, instead of as allograft was popularized recent decade only. Previously, the amniotic membrane was the main thing that was used. So what exactly happened? People, if proper debridement was not done, the eschar will be developed, which is nothing but the necrotic material as well as the fibrin material. And on top of it, if you apply this amniotic membrane, it gets sticky, and it is painful, and it doesn't get removed, sir. So the main aim of the treatment is first thorough debridement, as sir mentioned, complete tangential excision, and then apply, and then it will prevent in helping in formation of the new granulation tissue under the bed, sir. And the second question, as Venkatesh sir has asked about the burn center, why there is a very few centers in India. I feel this is my point of view, sir, but there are many factors like what you'll say is cost issues. People will think it is expensive, and then there will be revenue will be less. And the second thing is there will be high mortality, sir. People actually, many doctors doesn't want many hospital doesn't wants the mortality to accept the burns, especially, sir. And as sir also mentioned, the commitment and lack of trained personnel people also will be there. That is the issue. These are the three key points. I feel that is the reason many of the hospitals doesn't encourage burn center, or maybe doesn't want to open and continue as a burn centers. And if they
Just
have
one point here, sorry, Bara. See, regarding mortality, I had a 90% burns patient, 9 months of amenorrhea. So we took her up, we did a Caesar, we lost the mother, we lost the child. But the family came, thanked us, and went. So it is about your communication and transparency, and people should understand you're trying to help them. So that is the most important. So in that case, we have so many mortalities, but transparency, communication, genuine approach definitely helps. So you don't have to worry about mortality if you're doing the right thing honestly.
So one more question has been asked in this discussion about the acid chemical burns regarding the management, sir.
Yeah.
It's the most actually, as sir has mentioned previously, the acid burns and chemical alkaline burns. Alkali burns are the most dangerous ones, sir. Acid burns actually, the basic management is like similar to that of like trauma, like ABCD. We have to think of first of all decontamination the chemical materials, and do the airway breathing circulation maintaining this thing. And if we don't know the exact content of the acid or alkali, it is always, first of all, the best management is thorough vigorous saline wash, or running tap water is also a best one, sir. But this management has to be continued for 30 to 60 minutes until the pH has to be neutralized, sir. So that is the best management, sir. And stem cells question, I did not get the exact question, sir.
No, he is asking about stem cells, particularly in heart transplant.
Oh, okay, sir. Actually, head transplantation has been mainly done. It is an what you will say, sir, autogenous process, sir, which has been taken from the occipital and temporal sites and placed in the
Now
frontal
that
region.
he said, whether, Dr. Neelakandan was asking whether it's possible from a cadaver donor.
As far as my knowledge, there is no study has been done this in any part of the world. I feel so, sir, and maybe it is a welcome idea for us to do. Maybe we can try somewhere and we can do it, sir. But still, for the ethical issues and the things, we may need to do a lot of things to work on it, sir. Definitely, it is a maybe an eye opening for us to look upon on this stem cell treatment also, sir. Sorry for joining very lately and answering all these questions, sir. Actually,
What happened, Bara? Where did you go?
I slept off, sir. I'm so sorry. Yeah, sir.
There is a question in the chat box.
Yes.
Sir?
I think Dr. Swami has asked, do you see any difference in bone marrow response, such as leukemioid reaction and recovery from burns? That is, whether the leukocytosis, extreme leukocytosis, does it reflect on the outcome?
Interestingly, what we generally see is when you really look at the SOFA score we use and all that. So early days, SOFA score, we take into account platelets. Early days, the first thing that happens is day 3 or 4, if there is your total count is falling, platelets is falling, they are going to do badly. But if the count is up in this thing, we always feel that the patient is going to do better. If the count is going to go low, they do badly. And the count is, we see, 20,000, 30,000, 40,000, 60,000 total count and all that. Still, they may still do all right. But a low count is always a problem. Yes.
Augustus, can I ask you a public health question?
You're welcome, Rafiq. Nice to have you back.
Yeah, I just wanted to know whether you are talking about awareness, whether creating awareness on prevention would help reduce. Okay.
Say again, Rafiq. Sorry.
I just wanted to know whether more awareness on prevention is given, prevention of burns is given in our part of our country. Would it bring down the incidence?
Yeah, see, definitely, prevention is in the sense in Tamil Nadu, per month, at least 1 or 2 electricity board persons die. And most of them come to us, and most of them, when they go on the post, they don't wear a glove. Somebody switches on, and electric burns amongst the electricity board workers is very high. So you see, not even education, preventive steps taken there itself. So where to go to public? So definitely we need a lot of work on many areas for burns prevention.
Thank you, Augustus.
We do a lot of videos, and this Diwali also we are releasing quite a number of videos for burn safety and prevention. And first thing, simple things. When you go for medical rounds in the ward, they would have stuffed the paper in the computer and all these things where the things are getting hot. Okay, I always tell them, why a thing burns? You need oxygen, you need heat, you need a material that burns. Most of the times we say, eyes do not see what the mind doesn't know. That is where a burn starts. And also, we have about 30 neonates. So all of them, we use a thermometer to check the water, all the staff. They don't use the hand to check the thermometer. When they drink milk, we use a thermometer so that the temperature is correct. All these, simple things, preventive measures, if you take, you can definitely reduce.
Even in big hospitals, the way the short circuiting, and recently in Jaipur, it has happened. Periodically, it happens, and finally, the blame is pinned on the doctors. Recently,
Exactly.
happened in the quite a big hospital of Jaipur, the SMS hospital, which is quite a reputed hospital. There, I think 14 people have died after burns.
See, as far as electricity is concerned, one of the problems is we don't have steady power at all. So that is one of the problems. So for us also, suddenly from 250, it will go to 400, and a couple of all your safety equipment, everything goes, and you go for a shutdown. And see, our supply itself is not okay. So when there are surges, things tend to melt, then they stick together. So you cannot say it's entirely the fault is on one side. Our whole system needs a lot of revamping and safety measures.
Because hospitals with JCI accreditation, periodically they do all these fire drills and codes and other things. But does every hospital have such codes or fire drills periodically? Is it mandated? Being an
It is mandated. Even with our NAB, CA, all these things, we do, and we have these announcements, and we have an assembly area. People assemble. They're all trained to use the fire extinguisher. The training is definitely happening. But most of these burns, amongst children, it is about, you're making some vada, they'll pull that. Your milk is there, they'll pull. And parents running in the morning with hot water for another child, they pour it accidentally. And these accidents, very common, every day almost, yes.
Augustus, Sam, I'm asking another question.
Yes.
Do you segregate the graft, donor graft based on the blood group?
No, this is, the cadaver graft has got nothing to do with your color or this, only a temporary savior of life, and you don't have to have any kind of matching. You can use it on anyone. There is no need to match.
Any immunological reaction like graft rejection?
See, thing is, anyway, it's going to get rejected in about after 3 weeks. It will get rejected, definitely.
Okay.
So yeah, it will get rejected, definitely. But that is the time you need. I talked about trimodal distribution of death. So you buy that time, and that is where, patients are saved.
Oh, okay. Thank you.
Temporary skin cover.
Temporary skin cover, which really reduces the metabolic response to trauma. You can see the patient settling down very well.
Do you involve dermatologists also? Because they are experienced in managing toxic epidermal necrolysis or
yes, certain cases, not for burns, but we have, people getting admitted. There was a girl who took 1 tablet of levofloxacin and lost her entire skin. 98% loss of skin. So these people, they get admitted to our pemphigus and all these things. They get admitted to the isolation wards, and they are treated by the dermatologists.
Okay. The physiology will be the same.
Yes, nearly the same. Yeah, right.
Okay, I think
it has been an amazing day for us, and your interactions have been beautiful.
I just have one comment. Is that a long years of burning experience?
Yes. Yeah.
You're muted. Dr. Rafiq is muted.
Oh, accidentally is muted, maybe.
No, I said he has got umpteen years of burning experience.
Yeah, because I was in 2 major operations. I was in Sri Lanka with Indian Peacekeeping Force. I used to take quite a number of casualties from, say, from the center to Palali to Tambaram to MS Kirki. So that was the time, I developed my interest in trauma and burns, and I learned a lot then. We used to have what's called tubonic morphine. Just like, early days, we used to have this paints, color paints. We used to have with a small needle kind of thing. So we used to give that bubonic morphine to the patients. And so Army taught me a lot those days in burns management as well as trauma.
Yes, sir. I think we have done perfectly on time. So there was kind of 35 to 45 minutes of a nice lecture and reasonable discussion that followed. So I would like to also announce that day after tomorrow, that is Sunday, we have Professor Bose giving a talk for the 12th session of TMs and Medlogs. And I'll be circulating the flyer tonight. And we will have a recorded version of this talk also uploaded very shortly. So I think overall, it's been a great session. Thank you so much, sir. Thank you for taking your time out and spending and then giving an overview of burns to us. I think this will be a good introduction to for any one of the undergraduate or postgraduate student who would like to see the videos later on. Thank you so much. Thank you all for participating. And thank you. Bye-bye. Take care.
Thank you.
Thank you very much. And it's been a great honor and privilege. Thank you. Bye-bye. Thank you.
Bye.